So with that, I want to bring on Dr. Heather Mefford from St. Jude's Research and Dr. Ann Peduri from Boston Children's. Hi, both of you guys. Thank you for being here. I'm going to give a very informal introduction because that's my jam. That's the way I roll. But Dr. Mefford, I've known since she was a young investigator, and she is a phenomenal geneticist. I love working with her. She has really shined and made a place for herself, identifying genes that cause the early life epilepsies, really understanding how they work, understanding the genetic variants. And she's just a phenomenal scientist and an excellent person. Dr. Peduri is one of the clinicians over at Boston Children's and somebody I would definitely take my daughter to see. She's really been leading and pioneering, along with some others, the precision medicine and epilepsy, targeting therapies to specific genetic disorders, really understanding what those genetic disorders look like in kids. And so we're so lucky to have them here talking to us about what it's like to, what LGS looks like, and to take us through this amazing session with amazing speakers. So thank you guys both for being here. I will stop talking. I'm just really excited, and I talk when I get really excited. So with that, I'm going to hand it to you, Dr. Peduri.
Thanks so much, Tracy. So Heather and I will just give a few introductory remarks. If I can share my screen, Jeff, I'll do that. We are really delighted to be here with you, Tracy, and we can go a little short since you've done such a nice job of introducing the material. But Heather and I wanted to talk first about what we know about LGS in summary, but really what we don't know as well, which is really why we're here, to brainstorm new frontiers and really brainstorm together what we can do in partnership. And I think I'll add to Tracy's excitement to say that we're excited to be partnering across genetics and neurology, across basic science and clinical science, and partnering with families and people who do live every day with LGS and can keep reminding us what questions we need to keep asking, both in our clinical science and our basic science. So in terms of setting the stage and what we do know, certainly we have clinical criteria and ways of diagnosing LGS. We have a variety of causes, and we know that LGS is defined, among other things, by treatment refractory seizures, but also many other non-seizure issues that you'll hear about. And so when we think about multiple seizure types, a slow spike and wave EEG pattern, and a moderate to severe cognitive impairment, this is sort of the classic triad of LGS. This is what generally we would think about in a child neurology clinic or an epilepsy clinic. And certainly if you ask a child neurologist, you know, what do you think about when you think about LGS? These are the main features that come to mind. We know that LGS has childhood onset. We know that typically we have refractory generalized epilepsy with multiple seizure types that are defined, not necessarily required to have, but defined by the presence of drop attacks and other generalized seizure types. We have cognitive impairment in almost all of the individuals with LGS, a slow spike and wave or generalized paroxysmal fast activity, EEG patterns that Tracy had shown you, and that LGS also accounts for at least 5 to 10% of children with seizures whom we see. So this is often considered a rare condition, but in terms of its importance in the broad group of patients and children with epilepsy, LGS certainly does play a prominent role. And to add to that, in an epilepsy clinic, because the seizures are so refractory and the overall conditions are so severe, these are patients who are disproportionately going to be seen in a day-to-day clinic because they're going to need more frequent visits than somebody with a different form of epilepsy that might be well controlled, for example. So the impact of what we're discussing in the next 2 days really can't be overstated. This is a really important subset of epilepsy and one that's emblematic of many of these severe early onset epilepsies. We know that features of LGS evolve over time, as Tracy mentioned. There's a lot of overlap with other developmental and epileptic encephalopathy syndromes, including myoclonic astatic epilepsy, Dravet syndrome, West syndrome, which may evolve into LGS, Ohtahara syndrome, which can start in the first few days or weeks of life, and then evolve into West syndrome, and then evolve into LGS. And then also atypical benign epilepsies of childhood may start out that way and then evolve into an LGS picture. And again, we're not going to talk about the pre-LGS as much today, but I think the really important discussion points we might have is once we get to LGS, once we are in this group, or as Tracy sometimes says, this club that we don't necessarily want to belong to, but we're here and we're all in. Once we're there, what can we do about it? But I would invite everybody to think about, well, what happens before LGS in a child like Savannah? What happens before LGS in a child who might have West syndrome that's refractory or not refractory, and how do they then evolve? Because I think the impact we can have will extend beyond LGS to all of those children as well. And we know that there are various etiologies. And while not everything is genetic, Heather and I certainly have genetics as our focus in our research and our clinical lives. And so we are going to talk a bit about the subset of patients who have genetic epilepsies, because that gives us an opportunity to teach us about the underlying biology of brain dysfunction that's giving rise to LGS. It highlights new molecules and new molecular pathways that we might be able to target with precision therapies, which really is our long-term and ultimate goal here. It also can improve counseling, both in terms of prognosis and also recurrence risk for families. And so there are many reasons we clinically pursue genetic diagnoses in patients who have otherwise unexplained, non-acquired LGS. And these really, we hope, are not simply a diagnostic measure, although that provides a lot of closure and an end to the diagnostic odyssey, but really that it invites us to then take on the next odyssey of finding precision treatment. I'll turn over now to Heather.
Great, thanks, Anne. So we're really excited to have everybody here today, because the goal of, obviously, of this entire meeting is really to identify and think about how to address the gaps in our knowledge. Anne's told us a lot about what we do know, as has Tracy. And this first session, we're going to set the stage with 4 great speakers that I'll introduce in a moment, who are going to address what we know about the diagnosis of LGS and the treatment of LGS and the causes of LGS. But I want everyone to think along the way, and I think the speakers will address this as well, is that as much as we know, there's a lot that we don't know, and that's where we really need to fill in with our research priorities to tackle this disease. So as far as the talks today and what we're going to introduce this session with, so that we can set this stage, is 4 great speakers to talk about the clinical pathways, or the clinical presentation of LGS, the various causes of LGS. Thanks, Anne. So first, we're going to have Dr. Elaine Worrell talk about the clinical features of LGS and what we know, how we diagnose it, and kind of that journey to diagnosis, as well as what are the things that we can focus on as far as really knowing which patients have LGS. Dr. Patel from Nationwide Children's is going to talk to us about the varied causes of LGS. And again, here, I think, even though the goal is not to focus on pre-LGS, but to think about how do all of these disparate causes bring us to a common endpoint, and can we leverage that and think about where we could intervene either pre or at diagnosis of LGS. Dr. Anne Berg from Northwestern Feinberg School of Medicine studies outcomes. And in order to understand LGS and to have successful treatment trials when we get to that point, we need to understand what are meaningful outcomes, both from the scientific, molecular, pathway, biomarker standpoint, but also from the family's perspective. What are the meaningful outcomes that we need to be targeting for treatment and for a cure? And then finally, Dr. James Wheelis from here in Tennessee at the University of Tennessee Health Sciences Center is going to talk to us about what we do know today about treatments that work for LGS, as well as what are the opportunities for novel interventions to treat this and maybe eventually cure this disease. So with that, I want to encourage all of you, again, to think about during this first session what we know, but also have your brain turned on to think about where are those gaps, because we're going to try to address those in the second, third, and fourth sessions of this meeting. Like, what is it that we don't know, and how do we get there, and how do we help the LGS Foundation think about their research priorities to get there even faster?